Yeah, so my name's Nick and I'm a physiotherapist and strength conditioning coach, and Andrew is the same. So we see a range of patients and clients, people with acute pain, ranging to going to persistent pain as well. But we also see people who, again, don't have pain or injury and just want to get a bit fitter and healthier. So that's kind of the context that we're coming from. So just an overview of tonight. So we'll go through what pain is and its complexity. Then we'll have our first Q&A. And then in the second half, we'll go through why injuries happen, acute versus persistent pain, and how to manage pain. And then we'll have another Q&A. But again, feel free to ask a question outside of those times if you really want to. Okay. So to start us off, I've got a few things listed here. I've got a muscle strain, a ligament sprain, skin cuddle graze, and a bone fracture. So the first question I'll ask is, what do all these have in common? Again, you don't have to answer, but just have a think about it. And again, it's nothing too complicated. So one thing that they all have in common is that they involve some kind of tissue change, tissue injury, or tissue damage, whichever term you prefer. And the other is that often they're associated with some kind of pain. And generally, as the tissue heals, we notice that there is a reduction in pain, again, in most people. Okay, so tissue damage often occurs with pain. But can you have no tissue damage and pain? So yes, one example is if you were to take something out of the microwave and it's really hot, you touch it and you experience pain. But again, most of the time, you don't get any significant damage. And in the same way, if you were to hold a cup of coffee, same thing. And can you have tissue damage and no pain? Yes to this as well. So one very easy example is wrinkles on your head, on your face. And then because again, as you get a bit older, you have changes in your skin. And again, you don't really have pain. Well, not pain in the traditional sense, maybe just the pain of getting a bit older.
Brutal. Got more lines on my face than you, Nick.
I'm already starting to get a few. All right, so moving on, I've got here an image, an MRI scan of a 21-year-old male. So this is of I guess you can say the lower half or lower third of their spine. So just to orientate you, so this is looking from their left. So on the left side of the image is closer to the front of the body, and on the right side is closer to the back. So if you look where I'm kind of pointing, here's kind of the bulk of the spine. So you've got the vertebra or vertebrae. These are the big chunks of bones here. And then in between these, you've got discs. So they're the slightly darker part there. And then you've got the white spinal cord to the right. And then to the right of that, you've got the rest of the spine. So this is the part of the spine that's close to your back. So for example, you might have what we call the spinous processes, which point out. So if we go to where the arrow is pointing, we'll talk about the white arrow. It's pointing to one of the discs in this person. So you can see that it's actually coming out a little bit. So it's protruding a bit or bulging out, and it's kind of touching or pressing on the spinal cord. So if you were to show this to most people, they would think, from what you've heard about spinal cords and spinal cord injuries, how severe the consequences are, how catastrophic they can be, your natural conclusion might be that, this person must have a lot of pain, like it's pressing on the spinal cord. But what's interesting is that this scan was, again, of the 21-year-old man with this bulge, they don't actually have back pain. So again, this is just one example of where you can have tissue damage or tissue change, but no pain. And moving on to a different study. So this is a very well-known one where it was a big review of many other studies, and they had about 3 studies. They defined asymptomatic as people with no history of back pain. So we presume that they had no current back pain and no history of back pain, or no previous back pain. So again, it's a bit complicated, but I'll walk you through. So on the left column, you've got imaging findings. So again, all of these people, they had either a CT or an MRI of their spine. And these were kind of the findings. So common ones you might recognize, disc degeneration, or you might have heard this as degenerative discs. And there are many other findings as well. And going from, or to the columns to the right, you have all the different age groups that they were divided to. So they had people in their 20s, 30s, and all the way down to their 80s. So one of the things you would take away from this table is that, firstly, in each age group, you can actually have changes in the spine. So even people in their 20s who you would typically associate with being, healthier, fitter, like a large or fair proportion of them still had all or some of these changes. And then what you also notice is that as you move to the right, so as you get a bit older, you'll find that these findings get a lot more common. So what you can say is that because these imaging findings or spinal changes are quite common in people without pain, and they become more common as you get a bit older, perhaps you should, or you could say that these are normal age-related changes. Or another way of saying it is that it's like, or they're like wrinkles. They love to pathologize this. They might say, look at all these changes in your back, look at all this pathology in your spine, but they wouldn't say, look at all the pathology in your face. Just a little harsh, pretty harsh. And again, in saying this, tissue changes can be relevant in some people with pain, but it's not always the primary factor. And we can find this in other studies as well. So you can find tissue changes in people without pain. So again, in athletes, you can find them in other body areas as well. So for example, you can find cartilage changes in people with no hip pain. You can find osteoarthritis in people with no knee pain. And these are just a few of many, many studies out there. So to tie this back in, so what is pain? One definition you might have come across is from the ISP, and they define pain as or resembling that associated with actual or potential tissue damage. So this is a pretty good definition because it considers the role of tissue damage or potential tissue damage, but it also appreciates the complexity behind it as well. When I define pain, I probably would say something a bit more simple. So I might say that pain is an unpleasant feeling that kind of compels or drives you to take action or drives you to do something. So we'll quickly chat about nociception. So this is one way in which pain can be produced. So here I've got a diagram of a person with their nervous system. So you've got the brain and spinal cord in the yellow. You've got all the nerves that come out of it as well in the blue. And again, this is still, although it looks complicated, the actual system's a lot more complicated than this. And the network of nerves gets or branches off even more from this. You've got this all around your body, and they do things such as help with your sensory functions, your sensation, but also to control your muscle function as well. So at the end of all these nerves here, or most of them, you have what we call nociceptors. So they're what we call, or might call, danger detectors or irritation receptors. So they can pick up stimuli in the form of mechanical stimuli, such as pressure. It can be, or it can pick up chemical stimuli, such as inflammation, or chemicals that you might get from a bee sting, for example. And it can also pick up thermal stimuli, such as heat or cold. So if we take the example of if you would be stimulated there, and they would send potential danger messages through the nerves and up to the spinal cord and brain. And this happens very quickly. So, and if when the message gets to the spinal cord, the spinal cord can either turn up or amplify the volume, or it can turn down the volume of the message, so altering how much actually gets to the brain. And sometimes the message can actually get to the spinal cord, but stop there and not actually go any further, depending on what the brain tells the spinal cord. So you can kind of think of the spinal cord as like the assistant to a big boss, and the brain as the big boss. And they can kind of control what kind of messages they want to come through, and which again might be messages that the brain doesn't think is as important, or if for some reason the brain wants to get all the information or data in, it can tell the spinal cord to do that. So if the message reaches the brain, it decides what to do with it, and this is where the magic happens. So data that's coming in. So in this example, it could be the stimuli from the actual thumb, but it also takes into consideration the data from everywhere else. So such as what you're seeing, your sight, could be what you're hearing. So all of your kind of your receptors are, all the receptors around the body can potentially have some input as well. And the brain considers what's coming in, but it also looks at what's already stored inside your brain. So this is pretty much everything that you've picked up throughout your whole life. So this could be previous experiences. Maybe you've hit your thumb before and had a very bad injury. It could be watching other people doing that. It could be your beliefs about injury, pain. But it could also be things like emotion as well. So, and this happens very quickly. And if the brain believes that protection is needed, it will produce pain. So your brain kind of weighs up all the data and all the evidence saying to protect against all the data and the evidence saying you don't need to protect. And if the former is greater, then it will produce pain. And if pain is produced, the body can take some action. You can also draw upon or recruit other systems in your body. So we've been talking about the nervous system, but it can draw upon such as your immune system to produce chemicals to start the healing process, for example, at the thumb. And all of this is quite interesting. If we take another example of, if you're going to roll your ankle on the middle of the road, your brain might decide that, there are more pressing matters to attend. So it doesn't want you to get run over and die. That's a bigger concern. So you might not feel pain until you get out of that. But if we contrast that to maybe if you roll your ankle in your garden where it's pretty safe, you might feel the pain pretty immediately. So all this is very quick, very clever, and it's what keeps us alive most of the time. Okay. So pain is our alarm system. It tells us to protect, not whether our tissue is damaged and not how much our tissue is damaged either. So we can often have a high amount of pain, but not have a corresponding high amount of tissue damage. And I think one study that comes to mind is one where they looked at people with knee pain and knee osteoarthritis. They scanned all of these knees and determined how severe their osteoarthritis was, and also got them to rate their pain to see if there was a link between how much osteoarthritis they had and how much pain they had. But then they found that there was no strong link between the two. So basically you could have one, or you could basically have a little bit of osteoarthritis but have a lot of pain, or you could have the opposite. You could have a lot of osteoarthritis but only a little pain. So there's not that perfect relationship. And as we talked about, you can have both pain and damage, or you can have one without the other. Yeah, so pain, its purpose is to drive us to do something or to take action in order to protect us. So it can experience pain when there is potential danger or potential threat. When our pain system is working very well, it's usually very helpful. Again, it helps us to prevent or reduce damage. However, when our system becomes more sensitive or more overreactive, then it becomes less helpful. So that's where, if we explain pain as a buffer between, so usually there's a big buffer between when you feel pain and when you get damage. But when you have an overactive system, this buffer gets a lot bigger. So the activities that would trigger the pain are well beyond or far away from when you actually injure yourself. And to explain this, I often use the smoke alarm analogy. So our pain system is like a smoke alarm. Smoke alarms are, again, designed to keep us safe. They're there to tell us to potentially deal with the fire or potentially to get out. So when they do the job well, again, they save lives. In the same way for our pain, if it's working well, it can, again, prevent or reduce tissue damage. However, the issue is that, again, like with alarms or smoke alarms, they can go off for no apparent reason. Maybe there is some smoke in the kitchen, but again, you're like the fire is under control. But again, we'd rather this alarm system be more sensitive than less sensitive, because we'd rather not miss the fire and just deal with the false alarms we occasionally get. In the same way, we like that without pain as well. And the other issue is that sometimes, again, if we do have a fire, for example, the smoke alarm goes off, we deal with the fire, but the smoke alarm keeps going on. Well, after when we actually need it anymore. And in the same way, our pain system might have had a tissue injury initially, so we feel our pain, but then the tissue has healed. Like, we know our body is very good at doing that. We can still have pain long afterwards when it's not as helpful. Okay. So as we've alluded to, pain is complex and multifactorial. So tissue damage can be a factor in pain, but sometimes, after the tissue is healed, we can still experience pain, and that's when it can get really confusing, because we don't know what's causing the pain. It can lead us on to a journey of trying to figure out what's that one thing that's wrong for, is it tight muscles? Is it something that's not in the scans? But often there can be things in the background that aren't as obvious, but can actually be a big contributor to pain as well. And these things can be like stress, sleep, the amount of support you're getting, fear, anxiety, and so on. So a nice way to kind of conceptualize this is through the cup analogy. And if any of you have worked in health or seen a healthcare professional, you might have come across this before, because it's a really nice analogy. So the way I explain it is that each person has their own cup, and this is your ability to tolerate all the different stresses in your life. And these stresses are biological, psychological, and social. So they can be very different, and for each person, these stresses are very different. And so we've got a few listed here as a few examples, but pretty much, if our tolerance exceeds our stresses, so our cup is able to hold everything inside, we experience no pain because we're able to handle everything going on. However, if our stresses exceed our tolerance or our cup overflows, this is when we can experience pain. And this can explain why potentially in an acute injury where tissue damage can be a really big factor that's causing this cup to overflow. But again, as pain persists, this, again, because the tissue is usually good at healing, this becomes maybe not a factor at all, or a small factor, but for some reason you're still experiencing pain. And this could be other things going on, such as, maybe your beliefs that might not be as helpful about the pain. And we'll come back to this a bit later as well, more so in regards to how you can get out of pain. Okay, so we'll take a break there if anyone has any questions, and Andrew can help as well.
Combo. Sure, you got a question, mate.
No, mate, I'm just enjoying all of the analogies. They're so good, mate. I'm just enjoying them.
No question, mate. No question. I thought you'd have multiple.
No, mate. I'll save them for the end. How about that?
Okay.
I've really enjoyed it so far, though.
Write down an extensive list for later on.
Giving me homework, dude. Really.
Well, I want you to turn this into a Instagram meme.
You'd have to do something wrong for that. I don't think Nick's done anything close to wrong.
Yeah, indeed. Has anyone else got any questions? Because Bo doesn't, unfortunately.
You said you might touch on it a bit later, but I suppose in terms of that and cup analogy, if those stresses get too much, and obviously as a health professional, you might know that the acute injury is gone. How are you kind of going about helping them through those other stresses in their life, obviously within your field? Is that when it gets quite hard?
Yeah. Again, I'll go through it a bit more detail later, but because we're, as physiotherapists, where our primary treatment is through physical modalities, so like movement, exercise, activity modification. So we can definitely help through that respect. And although it's like a physical intervention, there's also like non-physical benefits as well. So like through movement and exercise, you can get like mental health benefits. So we can help indirectly. But then also, we know our scope of practice as well. If we feel like it's out of our abilities, we can always refer on. So if we feel like a person might benefit from managing their stress, for example, if we think that's a big issue, we might bring up the idea. Again, it's at the end of the day, it's the person, the patient, the client's decision if they want to address that at all. And so we're open to working with other health professionals when we need to.
Yeah, psychologists, dietitian, other health professionals do obviously have their place when needed. I would say that managing the stress and the sleep is a big one. I think we're in a very overstimulated society these days with phones and iPads and constantly on. A lot of people just don't get great sleep. So trying to hack their sleep so they get a little bit better sleep, more quality sleep. They have a very dark room, a cold room. They tune off from electronics, about an hour before they actually go to sleep. They remove the electronics out of their room. I think that has a massive influence. And then trying to reduce their stress somehow. And obviously everyone's different. And I often quote, there was a great study, I forget the author, in the States, where they did a study on where people were getting injured during a college season to figure out, is there going to be a spike in pre-season, off-season, during season? And there was typically quite a big spike around exam week. So every semester there was a big spike. And a lot of that would be due to obviously the psychological stress, the lack of sleep, probably because of the study, just the stress involved with obviously studying and getting through exams and that sort of thing. So that's not a bad sort of one to bring up. Sometimes I bring that one up. But I think, you got to stay in your scope of practice and refer out when needed. So,
Yeah. No, good question. Then.
Yeah, thank you. That's good.
Any other questions before Nick moves on?
No.
You can hold.
So there's one in the chat, I think.
Oh, there is.
Do you want to read that? I can't see it.
The one in the chat is, are we aware of a generalized time frame for when tissues should have healed and we can attribute a greater proportion of the pain towards psychosocial factors? Nick?
Did you want to start that? Oh, I can start. Okay. I think for most tissue injuries, usually they'll heal within 3 months. And that's perhaps where the definition for like chronic pain or persistent pain comes from, because usually things will heal within that. Sometimes often quicker.
It just depends on the tissue as well.
I think
like
most cases it would be within them.
It depends as well. Like you can get a hamstring strain that will take 4 weeks, but you can get a really big hamstring tear that may take a lot longer. So it depends. Like that's a tricky one to answer, but a lot of the healing response is often happening in the first 6 weeks. And then it will often be finalized within the first 12. So I agree with what Nick's saying. But it's a bit of a tricky one to answer on a general level, because every tissue is slightly different in a way.
Yeah.
Bo, you got anything to add there, mate?
No, but I came up with a few questions since
Oh,
you put me on
here
the
he is.
spot. I was going to ask, do you guys feel, you mentioned that like experiences play a big role in the development of pain, mostly because, you know, if you expect something to happen, it's going to make it worse, or, you know, perception of threat. Do you guys feel like there's a population or a group of people that are exposed to something that might be protective for them, like say an athlete? Or do you feel like, you know, some health professionals, when they're educated properly, would be better at self-managing their pain? What's you guys' take?
I would say, as a general rule, people that have had a lot of physical stress and mental stress in their life, say for instance an athlete or a soldier or someone like that, often copes better with pain purely because they've been exposed to it so much. So they often know, you know, any athlete that's gone through a career have often played multiple games per season, let alone throughout their career where they have pain. So yeah. Does that answer your question? Where are you going with that, bud?
I was just curious because there was that paper that came out about endurance athletes are good at dealing with pain for a long time. And then
right. Yeah.
resistance trained athletes are good at, I was just wondering if you guys had any other takes on that.
Yeah, I think it just makes sense, doesn't it?
Yeah.
You know, like
Yeah,
if someone's good at dealing with pain for a long period of time versus a hell of a lot of pain in a short period, but the pain threshold is actually higher. So because the strength athletes can cope with more pain for a shorter duration versus more pain for a longer duration with the endurance athletes. So I think it's very case dependent and sport dependent, and how they've been brought up as well. You know, that's a massive factor. You know, you don't want to be bringing kids up in a snowflake society, you know, where you're trying to eliminate pain all the time, because in an eliminating mindset, you're just setting your children and whoever it is up for no success. You're going to have issues going forward purely because if they think that they always need to get rid of pain, well, they're potentially going to have some issues going forward, because pain is a part of life, as we know. So yeah, the helicopter parent analogy is not a bad one. You know, pain's kind of like that helicopter parent cruising around the playground, telling their kid to get off the swing, get off this, or get off, be safe on this, don't hurt yourself. They're just being overprotective. So that's not the worst analogy I sometimes use. And I often use it with parents or with children or with adolescents. It just depends. Yeah.
Yeah. Eat some dirt, it's fine.
Yeah, exactly. Get dirty, get sick, hurt yourself. It's all good.
Yeah. I think
Thanks,
it's
guys.
yeah. I was just going to add, yeah, I think it's quite interesting because like a large part of it would be like in you growing up, how like you see, you know, if you grow up with a family member who had back pain and they ended up in a wheelchair, or maybe you saw them like struggling with it, like that could definitely be something in like your mind, like maybe not, you know, you don't think of it directly, but it could be something stored away.
Yeah.
Like for example, I was dealing with low back pain earlier this year as well, and I mentioned I think I was chatting to some person at the gym, and they were like, when I mentioned I had back pain, the first thing he goes is, "Oh, was it a disc bulge?" And and they're like, to me, like I'm like, no, it's probably not, like I don't have the symptoms or like that. That would make it like disrelated. But again, like if I was like a normal person and I heard that, I'd be freaking out. I'd be like, what do you mean? Like, do I need a scan? Should I stop listening? Like, but for me, I'm like, because I know all these things. So I think definitely like what you've learned, what you've learned from like other people and family, health professionals, it all kind of informs your attitudes, your beliefs, and that can contribute to like how you respond to pain as well.
100%.
Yeah.
It's a good point.
Yeah.
Well, if there are no more questions, we might crack on to the next section, and then maybe hold any questions you got up your sleeve if you got another one, Bo, or anyone else, until the end.
Sounds good. All right, let me. You can see that, okay?
Yeah, all good.
Okay. All right, so let's put this over here. Why injuries happen. So I like to use the envelope function, which some of you might have heard of already, but I think it's a nice model. It's not perfect, but it's a nice way to conceptualize how like physical activities can relate to, or how they can influence your ability to tolerate. So let me reword that. It's a nice way to show how your tissue capacity and your tolerance can change, because we know it's very dynamic, how it can change to what you stress, how you stress your tissue, how you load your tissue. So just to orientate you, on the x-axis, we've got frequency. So firstly, pretty much any physical activity can be put onto this, somewhere in this graph. So you've got, on the left, you've got lower frequency activities, and then going to the right, you've got higher frequency. So things that you do a lot more. And if you go from bottom to top, you've got like low load activities, or low activities that are lower intensity, lower weight, and then going up, you have increasing load. And then this black line you've got here is your envelope of function. So everything below it is, or are the activities that you can tolerate. So if we go through the zones, we'll talk about the orange zone first. So that's the zone that's outside of your capacity, that's too much. And this is where, again, if you're doing activities within this zone, you might experience tissue injury, tissue damage. But within the actual envelope, we'll start with the yellow zone here, so the too little zone. So these are activities that potentially aren't high enough in load or high enough in frequency, that if this is all you did, you would potentially lose the adaptations you've built up. So you might lose like bone mineral density, you might lose muscle strength or muscle size. An example I like to use is astronauts who go to space, because they don't have the same gravity, the same demands. They can lose, again, like the adaptations in their bone and in their muscle. And when they come back, it's a completely different context, and they're struggling, and they need to kind of rebuild what they would have built up before they left for space. Another maybe more relevant example is like bed rest after an injury or after a surgery. That's why we're always trying to, or people are trying to encourage you to move or be active when you do have an injury as much as possible, but again, not taking it too far. So in the green, you've got the OK zone. So these are physical activities that your tissue can tolerate, that potentially are enough to maintain what you have. And then in the blue zone, you've got the activities that challenge your tissue enough that it changes, that it adapts, but not too much that it would get injured. So if we take the example of on the left with the lifting. So I would say, let's say this is a bicep curl. So maybe for one person, lifting 2 kilos, 6 kilos, 10 kilos is good, it maintains their strength. Maybe for them, lifting 20 kilos is where they would get adaptation. And then maybe 30 kilos is too much. They might injure themselves, they might strain their muscle. Again, these numbers are just arbitrary. I think if there anything you took out of today was to go and lift 20 kilos, then maybe you weren't listening well enough.
A 20 kilo dumbbell bicep curl is pretty solid though.
Yeah, so it might work for some people. But yes, same for the walking as well. These were just numbers I put down there. So yes, when you spend maybe too much time in the yellow zone, this black line here will shift down. So it'll kind of move down like that, and it'll bring all the zones down as well. And in the same way, or similar way, if you spend time in the blue zone, the line will shift up. So everything will kind of move up, and you will have an ability to tolerate other things as well. So if I show you here, so this is what might happen after an injury. The black line shifts down. So I'll flick between the two, but you can kind of see kilos, but now after injury, you can only lift 10 kilos. And then the 20 kilos you were able to tolerate before might cause like more injury, for example. So yeah, this line can shift depending on injury. But the thing is, again, when you do have an injury, you still want to do as much as you can within your capacity, and not to spend, just time completely resting until it gets better. Because often if you spend too much time in that zone, you become more deconditioned than you need to be, because often there is something that you can tolerate, but you just maybe haven't found it. And And that pretty much minimizes the amount of work you have to do once everything's healed. And the thing we know is that tissue, again, they like stress, they love load. And the only way to, again, get back to where you were before is to start exposing yourself again, but maybe gradually. So for example, working in your new blue zone until it starts to shift and then building up again. Anything to add there, Andrew?
No, I think that's great. And you'll cover the cup analogy and,
yep,
you know, removing stuff out of the cup and building a bigger cup in a sec.
Yep. Okay. All right, so we'll talk about acute pain now. So again, acute pain can be associated with tissue damage or potential tissue damage, like we've spoken about. So this can be, it could be trauma, it could be surgery. And acute pain can vary in duration. So it can be a few seconds, or it can last, again, weeks, months. So a few seconds could be, again, like we talked about, if you touch something hot, when you stop touching it, more often than not, it will go away. And so usually acute pain will improve as the body heals, but sometimes it persists, and that's when it can become persistent pain, or some people call it chronic pain as well. So the thing with persistent pain is that for most people, it doesn't indicate ongoing tissue damage because, again, the body's very good at healing. And again, it can be, again, like a few weeks, a month, months when the tissue is healed, but again, pain can persist for way longer, it can potentially persist for years. However, persistent pain is more to do with the changes in the nervous system, or the nervous system becoming more sensitive, but it can also affect other systems as well, because again, pain is about your body thinking it needs protection. So it can not only does it produce pain, but everything else could be working a bit harder as well. So it could be like your sympathetic nervous system, your immune system. Your immune system could be your muscular system. So everything could be, just kind of working on overdrive, trying to fix something that might have already been fixed. Persistent pain can vary in duration, like we've spoken about, but again, typically it's longer than what we would expect for it to have taken to have healed. Okay, so some potential clues that you might have a sensitized nervous system. Things that hurt a bit before might now hurt a lot more. So the technical term for this is hyperalgesia. You might also notice that things that did not hurt before now start to hurt, which is also called allodynia. But other things you can notice, pain can spread, so move from the initial area. It can become less predictable. So maybe before it was more like mechanical, for example, where you did a movement, it got worse, and then you stopped doing the movement, it got better, but then it might, come on randomly now. Pain can also be influenced by your mood as well. So for example, if you're having a really stressful day, you might notice that pain flares way up. Whereas if you have like a nice, this can happen with acute pain, but maybe not as extreme. Because I think if you have an injury, you can still be, again, quite stressed, and that can make it worse than it is. Anything to add there?
That's great. I think the cup analogy is the next slide, isn't it? I'm pretty sure. Yeah, let's rock and roll with that.
Oh yeah, the other thing I'll say is that you can do something about persistent pain. It's not easy though, just because, especially the longer you've had it, the system's been wound out for maybe years and years, and it's not something that you can probably fix in a week. And I think people with persistent pain often try to find that quick fix because they've just had enough, and often like trying to go through the process of making your life a little bit healthier to help it in the long term. That's something that is not something that is as appealing. Okay, so bringing back the cup analogy. So how you can get out of persistent pain. And the most obvious way would be to reduce what's inside the cup. So reducing the stresses in your life. And the beauty of this is that because there are so many things that are potentially contributing, you have many options to reduce your pain. So for example, you might just pick, maybe you've been doing too much too soon. Maybe that's the easiest thing to modify. So that might be enough to get you out of pain. And the thing is, you don't have to fix all these things. It's impossible. You're always going to have some kind of stressor in your life. And you might just pick, again, like one or two that you want to work on. And at the end of the day, it's the choice of the person. As health professionals, we might give recommendations, but it's your choice. We can't, if people don't want to change, they're not going to change. Yeah, so that's the first way you can potentially get out of pain. The other option is to build a bigger cup. So this is building up that tolerance, building up that capacity, that resilience. And the thing is, everyone can do this. Everyone can adapt. Everyone has adapted throughout their whole life. If people say they don't think they can change, think back to, you've changed homes, you've changed schools, you've changed friends, and if you changed jobs, you've been doing this your whole life. So this is just another time you need to do it if you want to get out of pain. And if you also think of it like, if no one was able to run like a marathon their first time running, but again, they build up gradually, slowly, and then eventually they were able to do that. And in the same way, you can kind of build up your system just like that. And again, it just might take a lot of time and a lot of effort. So how exactly do you do this? It's pretty much anything that makes you healthier, that makes you happier, or makes you more resilient. So this could be, maybe if you've been quite inactive or not as active, you might start moving a bit more. You might start to push yourself a bit more physically, mentally. It could be maybe, again, if you have a lot of stress going on, whether it be at work, family, or so on, it might be having a chat to, someone professional like a psychologist. It could be going back to doing things that you stopped doing, because often people with persistent pain, they stop doing what they like to do, and they kind of wait around for the pain to be fixed before they go back to doing things. But often the doing is actually the fixing. So maybe you're not doing the exact thing they want to do, but like, for example, if you enjoy bushwalking, maybe we'll just get back to walking, which is maybe not as hard, or maybe something that has like a similar or the same benefits that you would get from bushwalking. And another key way to build a bigger cup is to learn a bit more about pain. So exactly what we'll be doing today. So learning about what pain is, what it means, what can contribute to pain, and also trying to find out ways to retrain your pain system if it's very sensitive. So trying to show your body that, it's safe to do these things. There's nothing to be worried about. You're just kind of recalibrating your pain system, because again, we need pain. You're never going to be pain-free. And people who set goals of being pain-free can be setting themselves up for failure as well, because we always need some form of it. Obviously, we want it to be manageable or tolerable. We want to kind of bring down the pain settings back to where it was very helpful rather than very unhelpful. Anything to add there?
No, that's great.
Awesome. Okay. So, yes, so building upon what we just spoke about, the one thing I will say is that you should be assessed by a health professional first to kind of rule out serious and sinister causes. Again, this is very rare. Most people with persistent pain don't have it because of persistent injury. Because again, if you talk to these people, usually they would have had all scans done, and they've hopped from, again, person to person, and then the serious things ruled out. And it's just the majority of it, or the majority of people with persistent pain, where we don't actually know there probably isn't one thing that's causing it. And it's probably a combination of many smaller factors. So yes, once you know that it's good to go, you want to look at the factors that are potentially contributing to your pain. And again, you can't change all of these. You might pick ones that you can or you want to reduce or manage. And you want to, again, look at all the ways you can become healthier and more resilient. And the thing is, often you might need the help of health professionals. So again, I think physios as one group can help, especially because we have a lot more time than potentially people working in the medical side. And we have time to kind of delve deeper. I think anyone who works in like health and fitness can potentially play a big role in this to, get to gradually expose people back to things that they might have been avoiding or been fearful of. Okay, let's move on there. So how to be physically active with pain. Again, you can often modify what you're doing instead of stopping, and this is often the better choice of the two as well. Because again, if you go back to the envelope of function, there's things that you can always do. Again, it might not be perfectly pain-free, but as we know, in people with persistent pain, the system is very overprotective. So what you're doing most of the time when you're with just a little bit of pain is perfectly safe. Having some pain rules can help, which we'll go through. And the other thing is trying not to give too much attention to your pain than you need to. So often, again, if you have pain, it's quite easy to kind of, start poking around, trying to figure out what movements hurt. And this can drive you, crazy a bit, which is not like we're all a bit like that. And the thing is, it becomes like a leaky tap where the more attention you give to it, the more you listen to it, the more you hear it. And the same thing for your pain. Sometimes if you kind of just shift your focus away from trying to fix pain to maybe just working on getting a little bit healthier, that the pain side of things will come a bit later. Whereas you might have noticed that you can walk 10 times as long as you could before you felt pain, but just so trying not to give too much attention to the pain itself. So how much pain is okay? So again, I want to reinforce that or reiterate that we want to be sure that it's nothing serious first. So like a fracture, we wouldn't poke into pain too much or at all. But again, once everything's clear, then again, most of the time you can poke into pain. But in general, pain is okay if it's tolerable. And what I mean by tolerable is, it feels safe to you, it feels comfortable to you. You don't go weak when you feel the pain, so you can still feel quite strong. So again, so if it's okay or tolerable during the activity, after the activity, and the 24 hours later, then generally it's okay. Again, it can worsen a bit as long as it's not dramatically worse. And why I say is that if you kind of push too far into pain, you can actually make your system more sensitive. Whereas we want to, poke into pain a bit, show the body that, nothing's going wrong, it's okay, then the body will kind of naturally recalibrate its like pain settings. However, with this, sometimes people can maybe be pushing into pain too much as well. And these people, we might want to do the opposite where, it's okay to back off sometimes and to let your system kind of calm down. So, and I think that's probably one of the difficulties we face as well, as people in health, trying to decide when we should get people to poke into pain or when not to. And so key messages from today. Pain is very complex and many factors and many stresses can contribute to it. Pain tells us more about protection rather than how much tissue damage we have or whether we even have tissue damage. Pain, when our pain system is working very well, it's very helpful. But again, if it becomes sensitized, it can become very overprotective. But it's, again, very possible to retrain our system, but it can take a lot of time and effort. I think that's everything there. Okay. All right, so if anyone has any questions, we can go through them now. Let me change.
Any questions, anyone? I will say one thing. A lot of people come in and they kind of search for the pain, after they've had a painful episode for a period of time, and their shoulder only hurts when they put their hand over the top of their head and behind their, doing weird things like that. And it only hurts them when they do that. And then they come in and they're like, it hurts me when I do this. I'm like, well, when do you do that? Like, only when I'm trying to search for, like, not necessarily search for it, but I try and just test it out and see where it's at. Like, obviously just don't do that, like just keep getting back into the normal things you do day to day and you probably will never feel it again. Yeah. So that's one thing some people do, and it's a pretty simple fix then.
Yeah. Sometimes it could be like if you do have like a painful movement and all you're doing is trying to, keep testing it, you could be sometimes like making more sensitive because you keep, to keep checking, you keep pushing, or sometimes it might actually be helpful to kind of, stop doing that for a little bit, and then we can maybe reintroduce that eventually. If it's a movement you need to do, like you don't want to do that.
Yeah, a good example is like bench press. Say, for instance, if the bottom of bench press is getting sore, well, you can use that towel that I've put up on the Instagram before, reduce the range of motion a little bit in the interim, and then slowly wean yourself off the towel. So then you're going all the way back down to the chest again. So you're sort of slowly building up that tolerance to that deeper position of the bench press.
Great.
Any other questions? Motion is lotion. I think that's the big one. All right, we've got a question on the chat. Jack said, does manual therapy have a place in helping people through pain? So, Nick, do you want to take that?
Yeah, I think definitely it can, especially if the person thinks that it will be helpful. Like I wouldn't go down the path of like, you got to use it on everyone, especially like if someone doesn't like being touched, like you'd probably have the opposite effect. They'd be like, get off me. And you probably would have, I don't know if it cause more pain, but they probably want to come back. So I think it depends on the person. I think acute pain can be more helpful, although I think it can help with persistent pain sometimes, especially if, the person with persistent pain hasn't had much luck. They haven't been able to find anything that helps. If you're able to show them like it helps a little bit, or even sometimes a lot, then that can give them a bit of hope. And then that's when you can kind of, maybe change the focus to the things that can give like long-term relief.
Yeah, you look at manual therapy as being a tolerating strategy, and I often give people multiple strategies that they can use themselves at home with, say, walking, or they can do their own massage or whatever. But it is a tolerating strategy that's often short-lived. It will give them some temporary relief. Manual therapy has a place to potentially, in the short term, reduce a little bit of someone's pain. But as Nick said, if they have a positive view of it, going into, say, some form of manual therapy or treatment, they'll probably feel better. And a lot of that's through placebo. You're not actually changing structure with manual therapy. You're not changing bone, you're not changing tendon, ligament, etc., muscle. That can't happen. Things are just way too strong within our body to create create enough force through those structures to actually change them with our hands. So that's important to understand. And the way that I often put it with manual therapy is, because you can hack this at home yourself. Often what you're doing is, the analogy I use is giving yourself a kick in the shin. So if your back is a little bit sore and I came over and I kicked you really hard in the shin, all of a sudden your back's not sore anymore purely because your shin hurts. Your brain can only compute and cope with so much information. If you give the brain a little bit more intel that is going to override the original signal, well, that's great. So you are getting an overriding of that original signal, often with manual therapy. So what we call the diffuse noxus inhibitory control, if you want to look that up. So it's effectively just distracting the brain from the original signal. So you can get that with manual therapy. So yeah, it has its place, but you're getting your analgesic effects mainly from exercise and building up tolerance in time. What do we got here? We've got another question. How do you guys go about addressing false beliefs? Example, my spine is out of place. I'm stuffed no matter what we do. Nick, do you want to cover that?
I think it can be difficult because sometimes, again, if we go back to where we talked about nociception as well, like you might have had this belief for a very long time, like many years, and then you come and see, this one person and they're telling you like, that's not true. And then like, it might not be enough to kind of convince them. And then I think it depends how you kind of address it as well. Some people can get quite defensive because it's like you telling them, that you're wrong. Everything you've been believing is wrong. So I think there is a way you can go about it. I think it does help if you have some rapport with the person. If they kind of, they like you, they trust you, it can be more easy to change beliefs that way. And often you might just have to do it you might sprinkle a little bit throughout, your time with them. You wouldn't do it all in one day. That might be a bit overwhelming. But the thing is trying to see how they came to that belief as well. And, seeing if they're open to a different perspective as well. And I think sometimes just like physically showing them, like, you just did that exercise and like you put so much load through your back and you're fine. Like not just saying, but often people need to experience it to see that, it's not just, you're not just like lying. You can actually show them that it's, it's possible.
I think one other thing is some people have got beliefs that were maybe what we thought were correct back, I don't know, 20 years ago or 25 years ago. And they heard that from a clinician back 20, 25 years ago. And now the research has changed. So you may frame it that with the current research that we have at our disposal now, especially in the last, say, 5 to 10 years, this belief has now shifted to this. So, so a lot of people come in with the posture myth, like my posture is the reason why I have pain. I need to fix my posture and all this. And a good way I just put it, I say, your best posture is your next posture, just implying that we were designed to move as human beings. We were designed to run, crawl, hunt, jump, throw, all these things. We're designed to change position regularly. So find a position that's comfortable, change that position every now and then and see how it feels. If it feels good, stay there for a period of time, then change it again. So I'm not used to sitting down for long periods. And right now we've been sitting down for about an hour. My back's giving me a few signals here and there to get moving. I've had my fair share of back issues over the years with stress fractures in my back as a late teenager, sort of 16, 17, 18. And, I currently right now, I would like to get going and moving for a bit of a walk because I'm not used to sitting down for long periods. But if I did this more often, where I sat down for a long duration and did it regularly, I would build up my tolerance to it. It's just because it's something different.
I would just add, I think sometimes if you might, I'm not sure if you're working with clients or not, but if you might send them like a credible source to kind of have a read of. I think sometimes if people have a read of it in their own time without the pressure of being with you, they can kind of you kind of letting them come to their own conclusion rather than jamming it down their throat. Maybe and it sometimes helps. It's someone else as well. It's not like you. It might be like a third party where there's no kind of relationship between them. I think that can help sometimes. Again, that's if they're into reading or watching or whatever you send them.
Yeah, it's good to have a nuanced view of a topic where you try and eliminate the bias. Because bias, I have a lot of bias towards certain things, but at the same time, I feel like I try and stay as nuanced as possible to make sure that we achieve the desired result and don't get across a biased viewpoint.
Yeah.
Any other questions?
I was just going to ask, it's kind of, I don't know if it's answerable, but we were talking before about expectations and then also about addressing harmful beliefs. So if we're say giving manual therapy, do you reckon it's a good idea to be saying, oh, we're not really doing anything? Or do you just save it for a better time? Same with saying, oh, the pain might be here for a while. Do you think sometimes it's better to, like Nick said, drip feed, or when's appropriate to do some of these things?
Nick?
What was that first part of it again?
First part
I can probably answer that first part about the manual therapy. Yeah. Look, I think it's still it's powerful for clients or patients, whoever you call them, to understand how manual therapy is helping them. Because if you don't get them to understand, then there is already, most likely, because they've seen other clinicians or they've seen a massage therapist or whatever, there are unhelpful beliefs surrounding that massage or the manual therapy. So I think them understanding how it works or it doesn't work is powerful, because then you can give them the tools at home to modify their symptoms and give themselves that kick in the shin or that reduction in pain for a small period of time, whether it be 10 minutes, half an hour, half a day, whatever it is. So I still think it's good for them to understand, because then they understand how to modify and modulate their own pain, and they don't have to rely on us without, because people think that we have magic hands. I can't fix anything with my hands. That's impossible. So if people understand that we aren't healers, we're not fixers, we are people that give solid advice, and at the end of the day, nature takes its course and helps the person overcome an injury, and the person can also help themselves get through persistent pain or something like that if they are tweaking their beliefs combined with more movement, that sort of thing, as we've discussed in those last few slides.
Yeah, I was going to say, I think it definitely can hurt your effect if you kind of explain, oh, it's not that special. But I think it's also part of like informed consent as well. If you explain like why you're actually like, would this person still be wanting this treatment if they knew that it wasn't actually doing what they were doing? So I think it's hard, I think, but it definitely can affect, like, I think there's things where, you know, if you think you're actually doing something with your treatment, you're more likely to get a positive result. I think it was in some dentists maybe, where they like told them like you might have had like the kind of, it was like the placebo analgesic or anesthetic, sorry.
Contextual effects, I think it's called.
Yeah. And I think, at the end of the day, you should kind of explain what it does and doesn't do, because again, depending on your narrative as well, you can maybe contribute to, I guess, maybe a little bit of dependence as well, if they think like this is the only way they can do it. But if you're going to show it in a way where, you know, you can do this, like, get the same effects from, you know, just moving or exercising or, you know, going for a walk with your friends, like, I think that's great. That's like empowering. That gives them options to do it themselves, so they don't think they have to come in here for like the rest of their life.
Yeah, and then they don't think they need to keep coming back for symptom modification, and they can change things themselves.
Yeah.
And I think as a whole, we've over medicalized everything in the last 100 years. And I'm currently reading this great book. You should all read it if you're really interested, by Dr. Ian Harris, called Hypocrisy. And it's about how doctors are betraying their Hippocratic Oath. Well, that's the tagline. And, you know, most of the advancements in people lasting longer and also just health in general being better is attributed to public health measures. It's not medicine. It is public health, so sanitation, et cetera, et cetera. And we've seen that in the last few years with COVID. Obviously, people, you know, the flu wasn't really a thing during COVID here in Australia because everyone was, you know, staying at home, and we were, you know, washing our hands and being very sanitary, and people weren't spending time outside. So I think it's important for people to understand that we don't need to over medicalize it, and they don't need regular treatment from someone to help themselves. But yeah, I get what you're saying, Bo.
Oh, I actually do similar to what you guys recommend. I wait until I've shown that it works, and then I go, look, I didn't actually do much. I just poked on you. It shows the pain can get better pretty easy.
Yeah. And I often say that, you know, like if I tickled you on your back or gave you, you know, a typewriter on your back, you'd probably get a similar result. And like Adam Meekins does a similar thing in his shoulder course. He gets someone on the ground that does like a passive straight leg raise, and does the passive straight leg raise up to a certain degree, and then he flips them over onto their stomach, and then he slaps them heaps of times on their hamstring, and then flips them back over, and all of a sudden their passive straight leg raise is better. And the neuromodulation side of things, it makes sense, you know, like I feel like we don't need to be specific with the manual therapy to see a change. So, you know, you could tickle someone or typewriter, or you could do some massage. You don't have to go deep as well. I think that's the other thing, you know, there's this kind of badge of honor, oh, you know, my massage was really hard, and, you know, you nearly bruised at the end of it. What's the point? Like, I just don't see the point. And Alexis did a recent review of all the research on that on his YouTube and his Instagram. And yeah, you just don't need to be pushing in all crazy pain when you're doing soft tissue work or something.
Yeah.
No, thanks. That was really good. Thanks, guys.
Good question, though, but I love it. Any other questions? Any other questions before we finish up? I think a few people have dropped off. Jamie, my boy, you got anything?
No. I was just having a bit of a think. you're talking about the cup, Nick, before, and how obviously mental stresses do play a sort of factor when experiencing pain. I was sort of wondering, to what extent do you think that, your brain creates symptoms which are obviously painful? Like, obviously you can have tissue damage present, but if you've, potentially recovered after the 12-week mark or the 3-month mark, to what extent does your head sort of play a factor in creating symptoms?
I think definitely it can be like a big component. I'm not sure if we can quantify it though, which is, I mean, just because of, again, how complex it is. And I mean, the best we can maybe do is like with questionnaires. And again, I don't think that can capture the complexity of everything that's going on. I think it's difficult to say.
I think one thing though, Jamie, is the pain is always going to be coming from the brain, but it doesn't mean that it's in your head. So we've discussed this when you've been coming and seeing me is, just because it's present and just because I'm saying that pain's coming from the brain, it doesn't mean that it's in your head. This is a subconscious thing because the brain is super smart at trying to protect you. So it's just doing its job. But what it does is your brain actually learns the pain. And it kind of snowballs to the point where it becomes so overprotective that it's sending all these signals that really shouldn't be there because you don't need to be protected. So you're a good case at the moment with it, Jamie, and that's why I've been so pedantic with you with your walking and all the other stuff that you've done. So, does that answer your question?
Yeah,
mate?
yeah. That clears it up a bit.
Awesome.
Yeah, no, appreciate it. Thanks.
Could I just add that in a chronic, I can't remember, complex regional pain syndrome, what actually happens is as it develops, they'll get like their skin color will change on the area that's painful, their whole leg temperature will change. So even though like a large reason that they're getting persistent symptoms is like, a lot of psychosocial factors, they'll actually get like a physical change to their whole like entire limb sometimes. Where those systems are just playing back with each other. So that's like a good example of when the brain kind of impacts the whole system.
A great analogy, mate, and great example, because I think that's worth noting. I just think that the pain science is just unbelievable, and what Lorimer Moseley has done in the last 20 years is just blowing my mind. The fact that you can create pain in an artificial limb for someone blows my mind. There was that study that Lorimer did where they had literally a prosthetic limb and they put the limb down. I'm pretty sure it was with a mirror, and they got the person to the point where they thought that pins and stuff were going into their hands and running a knife across this prosthetic limb, and they could feel it in their arm. It just blows my mind that can happen.
I think it's a point like the pain is very real. It's not like you're not just making that up. And I think sometimes that's the danger of kind of explaining, or like the difficulty of explaining pain this way as well. Like, because then they kind of think like, oh, it's, are you saying like it's not real? Or, and yeah, I think it's challenging, but I think it's important. I think people need to know, because otherwise they end up hopping between people trying to figure out like, what exactly is going on, like in their actual body part or their like tissues, and then they're just in a cycle of like never getting out.
I think one thing to note as well is some of the research suggests that pain science on its own and pain education on its own is not as effective as adding other stuff into a treatment plan, that be exercise, walking, lifting, whatever it is. So you can't just rely on a consult having pain education in it and thinking that someone will probably get just as good a result if you added the other stuff, the tolerating strategies and more complex things that may help the person going forward. So food for thought.
It's kind of like if you're telling someone, your spine's strong, your back's strong, but then you can't just leave it there, and they go like home and they kind of lift something and they still feel the pain. They're like, oh, like that was all wrong then. Like going through with them like in person where it's it's a safer environment, and kind of showing that it's possible. Like you're violating their expectations because they think it's gonna get pain, it's gonna be pain, but like it's actually okay. So I think that part of it is you need to actually experience what you're being told, not just like being told, because then again, everything else everything you've come experienced throughout your whole life kind of contradicts what you've been told at the moment. Yeah.
Well, thank you very much, everyone, for tuning in. If you've got any final questions, fire away. If not, that'll probably be it.
Yeah.
Cool. Sounds like that's it. Bo, what do you got, mate?
Oh, nothing, mate. I was just going to say goodbye and thanks, guys.
Bye. You're the only person that's put your you're the only person that's put your video on. Well, I'm glad you enjoyed it, Bo. I'm glad.
Yeah, it's great.
Guys.
Yeah. Nope.
It was awesome. See
Hey,
you guys.
Zoe.
Yeah,
All
thank you. Thanks,
Bye.
Nick and Andrew.
No worries. Absolute pleasure. Thanks again.